Straight from the Cutter's Mouth is now happy to be joined by three retina specialists for this journal club. First one of 2021. We're going to work our way southeast out to the West Coast. So starting Dr. Shaina Rubino, who is a retina specialist in Raleigh, North Carolina. Shaina, welcome. Your first time on the podcast.
Thanks for having me.
Next, we have Dr. Yoshihiro Yonekawa from Philadelphia, Pennsylvania. Yoshi, welcome back.
Thanks so much for having me on, Jay.
Last but not least, we have Dr. Mrinali Patel Gupta joining us from Orange County, California. Mrinali, welcome.
Thank you for having me.
So as par for our journal club, we have all the articles listed in the episode description. These are all articles recently published usually in major ophthalmology journals, but we're going to take a big boy step up and talk about an article that was published in JAMA, because ophthalmology articles do sometimes make the big medical headlines. So the first article we're going to talk about is the effect of intravitreous Aflibercept versus vitrectomy with panretinal photocoagulation on visual acuity in patients with vitreous hemorrhage from proliferative diabetic retinopathy. This was a randomized clinical trial from the DRCR-NET. Andrew and Tojic was the first author, and the senior author was Dr. Jennifer Sun, with a team of all-stars co-authors for this paper. Mrinali, tell us a little bit about what this study was designed to show and what they showed in the results.
Thank you, Jay. So this study, the DRCR.NET Protocol AB study, was designed to compare early treatment with medical therapy, Aflibercept, versus surgery for diabetic vitreous hemorrhage. It was a randomized controlled multi-center trial with about 200 subjects, and they were randomized to either Aflibercept ×4 and then PRN according to pre-specified criteria, or early surgery within 2 weeks. Now, overall, they found that there were no significant differences in visual acuity outcomes at 24 weeks or at 2 years, although the vitrectomy group did achieve visual recovery faster. It's important to note that a third of the patients in each group got the other treatment. That is, a third of the patients in the Aflibercept group ended up requiring vitrectomy at some point, whereas a third of patients in the vitrectomy group did end up getting an anti-VEGF injection, but only about 2.3 injections over 2 years. The vitrectomy eyes were far less likely to experience recurrent vitreous hemorrhage. They were less likely to need vitrectomy later on, and they were more likely to have regression of their NV. The risk of developing a TRD later, that is, after the time that the vitreous hemorrhage initially cleared or after it was removed surgically, developing a TRD later was also much lower in the Aflibercept group, about 9% versus 1% in the vitrectomy group. Adverse event profiles are pretty similar. In summary, this study suggests that both Aflibercept or early vitrectomy are reasonable options for treating diabetic vitreous hemorrhage with similar overall visual outcomes, both in the short term and the long term, but faster visual recovery, higher NV regression, lower recurrent vit heme rates, and lower rates of subsequent TRD in the vitrectomy group.
Amazing summary. I don't know if I have anything much to add. Yoshi, let's talk about this study in context of the study first, then we'll kind of go into clinical practice. So there are some limitations they outlined, right? So they talked about the retention or follow-up. There was a difference at 2 years. Some of these patients just, and this is unfortunately not atypical for proliferative diabetic retinopathy studies, some of these patients just simply don't come back. And 15%, for example, in the vitrectomy group, you don't have any results at 2 years. So that could definitely affect the results. There was also no masking, which is always something we think about with randomized controlled trials. And again, some people use Aflibercept, but other people use ranibizumab, bevacizumab, we don't know, but we'd assume the anti-VEGF agent's never been a head-to-head for PDR treatment between those three agents, so we don't necessarily know if there's a difference, but all things being equal, let's assume there are no differences. I mean, what are your big take-home points in terms of this study and what you first think of when you read the results or hear Mrinali discuss them?
Yeah, so similar to Protocol V last year, I think this is going to be one of the very hot papers that we all talk about in 2021. And I think overall, my take home is that long-term outcomes in general are probably not different, but patients who undergo vitrectomy see faster and they have better disease control. And I think it means that both options are fine and we can really tailor it to individual patients. So we can talk a little bit later about, what we would do for individual patients, but in terms of the study design and kind of some caveats, on one additional limitation, which I think a lot of people do, is observation. A lot of us, we observe vitreous hemorrhage and a lot of times it'll clear. And I think that many patients in the study may have improved similarly without any treatment. And another limitation is that visual acuity is measured, but there's not a good way to measure vitreous hemorrhage. I think there's a little vitreous hemorrhage that's not visually significant versus LP dense vitreous hemorrhage, and not all vitreous hemorrhages are equal. And in the study, the vision was more or less equal, but it was a bit worse in the vitrectomy arm. And the last limitation, I think, is that something we have to be careful about. Oftentimes, we'll have vitreous hemorrhage from PVDs, posterior vitreous detachments. And in this study, the vitreous hemorrhage had to be from active PDR, but you just have to be really careful when examining these patients. So when a hyaloid pulls on regressed NV in an eye, for example, that's had really good PRP before, it's been quiet for years, you pop a new PVD, you'll have vitreous hemorrhage, and those patients should be observed, and you don't need injections there.
Well, that's a great point. And to that last point, I mean, we've all seen those patients. I saw a patient 2 days ago with history of trauma, remote PDR that's been regressed for years, and then they show up and you look and it's just the hyaloid's lifted. And if the hyaloid lifts off some of that regressed NV, some of those vessels never go away. I mean, they're always physically there. It does not mean the patient is active. Shaina, anything to add? We'll get in, and we can kind of maybe segue also into clinical practice, what this does for your patient recommendations.
Yeah.
I mean, one thing I was just going to ask is Yoshi talked about the differences between different types of VH. I mean, that's, again, really hard to quantify. In your experience qualitatively, does that kind of, for you, dictate whether or not you take a patient earlier to surgery versus anti-VEGF injections?
Definitely. I think, patients that come in with like a dense vitreous hemorrhage that, are LP and are high functioning, I'm much more inclined to take to surgery, especially if they're pseudophakic, that sort of thing. Much more inclined to take to surgery than somebody who has a mild vitreous hemorrhage and 20/50 and sees a couple of floaters, but otherwise feels like they're doing pretty well. The other thing I was going to add is that, to be honest, clinically, I don't do a lot of injection monotherapy for PDR patients. And I mean, to each their own, and I know there's a lot of people that do that, but in my experience, I think diabetics, especially diabetics with PDR, have at some point been non-compliant or lost to follow-up, or are certainly capable of being lost to follow-up. And I really worry about treating those patients with just injections. And this study didn't account for patients that maybe could have gotten injections, and then once the vitreous hemorrhage cleared, gotten PRP on board afterwards, which is honestly how I often manage those patients if I'm going to keep them out of the OR. So I would treat them until the vitreous hemorrhage clears, then put in good PRP and hope that that will kind of keep them quiet. Like I said, especially if I'm trying to keep them out of the OR for one reason or another. But I think there's good data and papers that support that, and support that PRP can keep patients from coming back with disaster detachments. So that's one of my criticisms, I would say, of the study in general, but that just wasn't included.
Great point. And to your point, they looked at patients at baseline characteristics. About 42% of the patients in the Aflibercept group had PRP previously, 55% in the other group. Again, that prior PRP could be many things. That could be a few spots in the periphery. That could be a very full laser. And those will alter your outcomes a lot, I think, in terms of how easy a surgery is, how likely they are to just regress with anti-VEGF and clear. I think those things definitely play a role. And the other interesting point I'll say, let's looking at the baseline characteristics, the A1Cs, I always look at A1Cs in these diabetic studies because these tend to be more compliant patients from the beginning. I feel there is a bias that's always implicit where you're more likely to enroll a patient who will probably follow up in a study because you don't want to have patients drop. And B, you're more likely to have a patient be convinced to do all those visits if they're compliant in the first place. And so I always look at the A1Cs to kind of say, okay, is this comparable? I mean, the A1Cs were 8.7 and 8.3. That's comparable to other big diabetic studies like RISE-RIDE, Vivid Vista, but is that the same as everyone's clinical practice? Raleigh, North Carolina versus Orange County versus Philly versus Miami, depending on the demographics and depending on the socioeconomic status of the patient, that might be an underestimate of our population, or it might be right on the money. So that also is going to play a role. Mrinali, again, we're taking this conversation back, and you did a great job describing. Just anything to add on top of what Yoshi and Shaina said, and then what about this sort of idea? So like, I'm going to put the question to you that the listener is saying is like, okay, patient shows up in my clinic. when do I decide to take them to surgery, right? That's like the most common thing a fellow will be like. It's like, obviously there's patient factors, they have input, some of them don't want to have surgery, some of them have medical issues, but all things being equal, does this study affect your decision tree at all?
The study largely lends support to, I think, the practice many of us have, which is for most patients, unless the vitreous hemorrhage is super dense or there's a fellow eye issue where visual rehabilitation needs to be done sooner, I tend to treat most of these patients medically. And like Shaina mentioned, I do add laser when the view permits, because there is a history of non-compliance that led to this situation in the first place. And I think that the, as she mentioned, the worst rates of NV regression, the higher rates of recurrent hemorrhage, and the higher rates of TRD in this group likely reflect, in part, a lack of a complete PRP in these eyes. And maybe there's also a component of the hyaloid still being there to contract over time. But I think in summary, this just lends support to either option. And as Yoshi mentioned, tailoring the treatment as is needed. I'd go to vitrectomy sooner if they really needed faster visual recovery, or they had super dense vitreous hemorrhage or tons of membranes threatening the macula, and I thought they were going to disappear and then come back in with the TRD. I find that most patients are super compliant postoperatively, even though they may not be over the course of 1 or 2 years for repeat injections.
Great points. And I think the other thing that's interesting when you talk about the decision tree and adding PRP, I always try to think, well, why didn't they do that for this study, right? So why didn't they build in that? And I would guess, and you guys can chime in, I always try to, it's helpful for fellows or anyone thinking of designing research. I think the thing that would be hard to standardize here would be how much PRP is done in each of those subsequent sessions, especially when you look at the contributor list at the end. DRCR studies are amazing because they pool people from collaborators from all across the country, and some of these sites are contributing 1 or 2 cases. How do you make sure it's so standardized? Well, it's a lot, even though it's not completely standardized because you have a surgical component, at least you can sort of standardize the injection part of it. And then the surgery, you can say, well, they did, vitrectomy and full vitrectomy, whatever, cleared out the blood and laser. So maybe that's a reason they chose not to do that. Maybe it just got it would be a huge limitation, is that Mrinali sees them, they clear and she does 500 spots, and Jay's a little wimpy, so he sees them and he does 50 spots because he just wasn't feeling it that day in clinic. So that also probably plays a role. Yoshi or Shaina, any final thought? Oh, Shaina, go ahead. Yeah.
I was going to say, especially considering that, I mean, this wasn't a huge study, so I'm not sure that the power would have been sufficient to account for the variability in PRP, even if they did try to quantify it.
Absolutely. And then you just wonders, again, how many patients you're getting from each site. Given that there are so many sites, I would guess that it'd be ambitious at any site, even a busy clinical site, Yoshi, like Mid-Atlantic Retina, to get more than a handful of patients. I think for fellows or residents, medical students, you have to understand that these multi-center trials, they're pooled data, but it's really rare for a single site to generate enough on its own that's super meaningful. So you couldn't even really do sub-analyses. The studies are never powered for that. So we're going to move on to our next paper. Yoshi, one last thought?
Just a final thought that in reality, I think it's really going to be a combination, like we've all been discussing, whether it's injections, vitrectomy, and I think treating patients with diabetic retinopathy, it's really an art form, more so than treating patients with AMD or vein occlusions. We just have so many different options at our disposal, whether it's laser, PRP, focal, injections, steroids, surgery, observation. And so I have a lot of fun treating patients with diabetic retinopathy, and this paper kind of provides support for 2 modalities, I think. So it's good for the field.
Terrific. Well, we've got our next paper, which is a gender compensation gap for ophthalmologists in the first year of clinical practice. This is by Sasha Gia as the first author, and a huge team of all-stars again. Lama Al-Aswad was the senior author, but you've got some people we know very well. I know personally Steve Getty, if you're from Bascom Palmer, Janice Law from Vanderbilt, Yasha Modi from NYU, Jeffrey Suhu from Colorado, Royce Chen from Columbia, and I don't know personally all the other authors, but I assume they're all involved in residency leadership or some sort of advocacy based on their affiliations. And so this was a fascinating study that Ophthalmology has published. And it's also fascinating because we've kind of entered this brave new world where these papers get published online in pre-proofs. And then sometimes we had one instance where we took a paper on the podcast and Yoshi was there and we kind of we picked it apart and we saw some issues, and then I found out after the fact that that was the pre-proof, and the authors hadn't even finished their proofs to modify some of the things. So forgive us if we say anything that may have been changed to the final published version, but this was a cross-sectional study, basically a survey that was sent in January to March of 2020. So interestingly enough, right before this pandemic kind of broke loose and caused shutdowns in the country. And it was sent to residency program directors and ophthalmologists who had just finished residency training, anyone basically within the last 10 years. And they asked them very simple questions: their gender, did they do fellowship, what state they practiced in, and then their salary. And then the thing they looked at was, what was the base salary with bonus? So basically, what's your take-home pay before tax in the first year? And then they would account for bonus in some instances. And again, forgive me, everyone has a different bonus structure, but they had a multiplier they added for bonus for certain instances. And essentially, I think one of the hypotheses was, do women get less in the first year of practice than men? This has been brought up in several fields, not just in medicine, but it's become more of a topical issue in medicine. And the take-home analysis is yes. So if you take, it's not a huge study again, but you have almost 700 respondents who were within that 10-year period, slightly more women than men, and they on average took home about $33,000 less than men in the first year. And that was significant. And if you adjust that after analyses, it comes out to about 27,000. And this was significant whether or not you controlled for work, clinic, OR, because there's always been argued, for example, that one of the reasons is women are working less maybe, or they're taking more time. And the truth is that it did not matter. No matter what analyses you're in, there was a correlation between gender and income, where people who were female got paid less in their initial salary. They did also look at and ask these people, did you negotiate your salary? Which is a fascinating question. Did you actually sit and ask for a higher salary? They didn't find an association between gender and attempt to negotiate, but on a separate kind of analysis, more men reported they felt they were successful negotiating. That's a subjective feeling. Maybe men just think they succeed and they didn't, but they said they did. So the big take home was, there is a salary difference here. They don't know why. They controlled for many things to say there is it, but it's actually, this is I think one of the most fascinating studies we've seen, because it really lends a lot of credence to things that people have said and debunks a lot of the theories for why people say, well, this is not a big deal because of, these issues of women working less, or clinic OR ratios, or the sort of lifestyle jobs that women pick over men. This is controlling for that as best you can with 684 respondents. So Mrinali, I'll let you go first and we'll work our way around. What are your take homes? You see this study, you read it. What are kind of your big take homes from a study like this, first of all? We can talk a little later about implications for policy or what we should teach our people, but just on the surface, how do you respond to this?
I agree with you. I think that this study is powerful in the sense that it controls for many of the confounding factors that people have brought up. There are some things that aren't controlled for example, the actual clinical volume that people were stepping into, or their clinical volume that they ended up having over that first year or two. But nonetheless, I'm not surprised by this, because a similar thing has been found across many different specialties in medicine. It's been found across many different professional areas outside of medicine. And I think we'll talk about this more, but that points to the ever more importance for reducing sources of discrepancy, whether it's having a set salary for particular positions that with a very narrow band, or whatever else is needed to do so. But I think it's an interesting study for all these reasons.
And I'll quickly just touch on some limitations, if we can add more if you find them. The things they talked about, obviously survey-based study. You're relying on people to report. You don't know if people are being honest. It's anonymous, so you can't verify the data that they're reporting. Again, there's only select sites that distributed this study. So again, it's not maybe capturing the whole country. And overall, it's not a very high rate of representation. 684 people, if you think over the 10-year period, how many people graduated residency in that time period, you're capturing a very small proportion of that population. So this is not the end-all be-all for studies. The other thing they also reference a limitation, which is a huge one. And any detractor or someone who wants to lay a devil's argument here would say, well, what about other reasons? Maybe women are more likely to take lower paying jobs because they prioritize geography or proximity to family versus taking a higher paid job. They didn't take the highest paying job that was offered them for that reason. We don't know that. But there's still a lot for food for thought here. Shaina, any other things you want to add first about this paper before we can, I'll save the discussion about what we can do better or what we should take to improve things.
No, I would echo what everybody else has said. I think they did a really good job controlling for things. I think, I hate to say that it's not really that surprising. I think, you know, this is seen in a lot of different fields. I think the first thing is identifying that there is a disparity. And once we've all agreed that that's the case, then I think that's step one in the process of rectifying that issue.
Yoshi, you can also talk about the paper, and now we can kind of segue on the discussion to, does something need to be done differently, or do we need more information, or can we do something differently in how we advise employers, advise future employees or women or men who are going to get jobs? What are kind of your philosophies on this?
Yep, just gonna say it straight out. I believe that there is sexism in the hiring process, and not just ophthalmology and medicine, but everywhere. In ophthalmology, maybe it's more prevalent in smaller practices, perhaps, where there's no standard contract and more room for negotiation. But this study really makes that suggestion. You know, women get paid less. And remember that this study looked at only first-year salaries, and the numbers probably diverge even more when you're mid-career potentially. But it is very complex. And like you mentioned before, people who don't share such views often argue, hey, women are more likely to overall work fewer hours and take employee positions. And this study did show that trend too, though. More women were more employed by university practices, and more men were in private practice, where you usually get a higher salary, and women did work fewer days of the week. And the authors do control for this, but there's always a limit to how much statistics can control. And I think it's a really important study. Kudos to the authors. And I think this should really be a launching pad for something more prospective and more granular, because I think this phenomenon is real, but we need to figure out why.
I would totally agree, right? And this is not based on the results of the paper, Yoshi. We can't say this based on the results of the paper, but I would just anecdotally say this is for sure a problem. And you talked about sexism. There's a very strong statement, but there's two types of sexism, just like there's any types of discrimination. There's overt discrimination, there's unconscious discrimination. And I think that there are sometimes moments where there is unconscious discrimination, where assumptions are made. Well, we offer this person less because maybe they want to work less days a week because they want to take care of. Well, that assumption should not be made, right? That is not an assumption you should make. That is the responsibility of the employee. If they choose to do that, then that's their choice. They should bring that up. And that could be a man or a woman. It shouldn't, and discrimination works the other way. Sometimes it's like, well, why are you a man and wanting to take paternity leave or to take reduced hours to help with childcare? Well, we need to kind of break some of those societal barriers. It can work both ways. I would think that one of the easiest solutions to this, which no one wants to do, and it's becoming even more nebulous with new types of employers, like different types of practice organizations, private equity organizations, is there's got to be transparency, right? So if there was transparency, I'll tell you the best jobs I've seen fellows interview for, they provide the fellow, either it's the previous junior associate or the practice itself will provide the fellow with the exact contract. This was how much that person was offered. This is their pay structure. And that way there's no sort of question that you're getting a deal commensurate to your value. And generally the value should go up over time, assuming there's been a gap between the hiring of the previous person to adjust for cost of living and inflation. So there's usually an increase over time. And we should demand that from people. There should be that sort of transparency. I know that it's kind of verboten that you don't bring up money until late in the process. It's kind of like dating. You don't bring up money on the first date, and you don't bring up money the first time you talk to a practice. But you have to talk about it at some point. And I think we're so conditioned to just be like, okay, med school admissions, sign on the dotted line. Okay, residency, I submitted my list, I matched here. Okay, fellowship, I submitted my list, I matched here. That you just get an offer and you're like, okay, this is my offer. So part of the problem is we need to teach our residents and fellows to negotiate. But it would be way easier to negotiate. And this is going to go into our next paper about transparency in the match, but it's way easier to negotiate when you have equal information on both sides. If they know how much they paid the last person, they know they're getting a good deal if they hire you for less. And I'll give you an anecdotal example. I had a female mentee who applied for an academic position, which generally have standard contracts. And I know for a fact that this person got offered, who had seniority over another man applying for a position, got offered $60,000 less for the same position but they're just told, hey, this is a boilerplate standard academic contract. Why does that happen? I don't know. Is that overt sexism? Is it just implied? Oh, we know they're going to be less productive because these studies say there's productivity is less. Well, that can be a circular argument. Maybe they're less productive because you're giving them less opportunities and you're paying them less in the first place. But anyway, that's my little mini rant. Mrinali, I'll let you go first. Anything else you want to add or comment?
No, I think you guys all brought up great points. This is important for us to understand and to understand in more detail so that we can find ways to move forward. And whether that's teaching folks to negotiate, both to want to negotiate and how to negotiate successfully, or whether that's eliminating bias, or moving the field towards an era of transparency or standard contracts. I think most people want to feel that the contract they got is quite similar within a range and various factors to what prior hires have gotten, both because it's fair and because it reflects the culture of the practice. And so I think this, as Yoshi said, is a good starting point to really move our field in the right direction.
I think Shaina has a point to add, but my only thing is this is exactly, I get very frustrated with this. This would be the same thing as going to McDonald's to buy a Big Mac and being like, I want to order a Big Mac. How much does it cost? And they're like, well, how much are you willing to pay? It's like, there's got to be some sort of standardization at some point. Otherwise, you never feel quite you're getting a good deal. And honestly, $30,000, I know it adds up. This is not a significant amount of money for healthcare organizations that make millions upon millions. If they're profit generating, that 30,000 is not justifiable, right? Even from a business standpoint, to have an employee feel like they're not valued. But Shaina, go ahead.
The one thing I was going to add is that I know a lot of people listen to this podcast that are fellows or residents, and you mentioned something that I really think should be emphasized. Looking for a job is so different than looking for fellowship or a residency position or anything like that. The tables are very different, and I think the onus is on the applicant to really do their homework and really make sure that they understand the practice that they're signing with, and that they've asked around, to their mentors or other people who have left the practice, et cetera, et cetera. It's a really different process. And I think too often, sometimes people treat it as if they're applying for a fellowship or a residency position and don't do that extra legwork. And that's how people get into trouble.
Yeah, just to piggyback off of that, it's about a lot more than the numbers in the sense. How these things are handled reflects the culture of a practice that you will hopefully be in for the rest of your life. And so, we should all aspire to join a group that values us and that views us all as equals and has some standard ways about which they go about everything, whether it's starting salaries or promotion and partner tracks. There should be a standard that everyone falls into to help eliminate these issues, and it's a better culture to work in.
And to that point, I don't think the average applicant is trying to sucker someplace into paying them more than they're worth. I think they just want, like you said, Mrinali, they just want to be paid a fair salary. But I think part of the problem, though, is that you're taking people who in medicine, most people have not worked in another field, they've not worked in their job. They're frankly not used to negotiating very strongly, although obviously there's a business side to medicine. They're used to taking care of patients and submitting reimbursements and things like that. And you're putting them in a position where maybe traditionally they'd interview at a university with a standard boilerplate contract, or they'd interview with a practice run by physicians who are other fellow physicians. Now we have much more in both the university side, organization side, practice side, private equity side. We have so many more business people who you're negotiating with now. You're negotiating with people who for a living win these battles on a day-to-day basis. You can't go it alone. That's why you need to get your mentors to help you. That's why you need to show your contract to people. That's why you need to, if you're really worried, get a contract lawyer and review it with a contract lawyer so you don't end up in a bad position. Because you can't assume, unfortunately, anymore that the person across from you has the same negotiating experience. They don't. They are much better at this than you. This is like if you were trying to have a retinal surgery discussion argument with somebody who had never done a retinal surgery. It's just not an even playing field. So anyway, off my soapbox. Yoshi, any last thoughts before we move on?
All of this reminds me of what my fellowship program director, Tariq Hassan, told us during the job search process, that this is the first time that you're in control. And so you pave your own path. So it's okay to negotiate. Don't accept, what you're just handed, and take control of your future.
I love it. And that's going to tie into the next article, which is the case for transparency in the ophthalmology residency match. This was an editorial written by a group of doctors from Boston, Massachusetts. And Shaina, you're going to tell us a little bit. Again, this is not a traditional research study. We don't have nuts and bolts and numbers to break down. This is more about ideas. And tell us a little bit about what they wrote about and why they think this is important.
Absolutely. So, again, this is an editorial, and basically the authors initially argued that the current match system is flawed because applicants are forced to make rankless decisions based on inconsistent and limited data. Largely information that is the product of, quote, hearsay, word of mouth, and chance encounters. The sources of this information may be unreliable or biased, and the information may reflect factors that are unimportant to an applicant. They further argue that programs have access to, quote, detailed qualitative and quantitative profiles of each applicant, and they envision a future where applicants' lists are similarly well informed. So as a result of that, the authors propose that most likely through a centralized system, there should be a database of information about each residency program available to applicants. Possible variables include patient demographics, surgical exposures, board pass rates, et cetera. And the authors point out that most programs already have access to this information. It's just a matter of making it available to the applicants. And they recognize that the programs may be reluctant to release data that is unflattering, and also acknowledge that this could encourage applicants to place unnecessary weight on granular information. So a couple of points I'd like to make. I think transparency in the match is a laudable goal. I imagine that especially with COVID and the lack of opportunity to visit programs, it may be difficult for applicants to track down information. And I do think it's important for residents to be happy and comfortable with where they match. Publishing these metrics could have some additional upsides that the authors didn't mention, such as encouraging programs to improve their numbers, but it could also lead to other issues, such as emphasis on quantity over quality. Moreover, we are assuming that the information reported to this centralized system is accurate and not inflated or exaggerated. Obviously, inaccurate information would be harmful. And I also worry that while surgical exposure and some other variables can be quantified, I'm sure we can all agree that some very important things would be really difficult to put in an Excel document. Collegiality, feel of the program, being obvious examples. But I disagree with the premise that the opacity is unidirectional. From my experience interviewing applicants for both residency and fellowship, letters of recommendation are often overly flattering or boilerplate. Grade inflation is a concern, and we don't even assess things like surgical aptitude. We should keep in mind also, current trends in how the system is evaluating applicants. Most medical schools are moving towards pass-fail grading and eliminating class rank reporting altogether. And even step one is transitioning to pass-fail. So point being, programs also have access to imperfect and limited information, which appears to be evaporating by the year. I think moving forward, there's going to be tremendous emphasis on performance during away rotations to compensate for that. But Jay, you're obviously very involved in the residency program at Bascom, so I'm curious what your perspective on that particular issue is.
We're going to do a whole episode about this year's process. I'm going to bring on matched applicants after the match. I'm going to bring on some of my friends who interviewed, and we're going to share war stories because it is fascinating how little information you get in a virtual setting, both sides. I agree completely with you about the opacity issue. It seems like we're balancing the transparency issue by making things more opaque from the applicant to the program rather than making it more transparent the other way. I also agree. I like the idea of this database. I think it's commendable because the thing is, applicants are sharing this information anyway. They're inventing numbers. They're coming up with granular points. It was Student Doctor Network in one lifetime. It was Reddit for a different group of people. And now it's this Google Doc sheet that the applicants think is secret, but really everyone reads it, so everyone knows about it. And it's like, you read some of the things that are written on any of those platforms, no matter what year you're talking about, and it's simply wrong. It is just wrong. It's the same as going on social media to get your news. Some things will be true, some things will be sort of false, and some things will be blatantly dishonest and not true. So how do you standardize that? Well, you can't stop people from talking about it, but maybe if you create a database, maybe they can point to something objective. I think you hit on all the reasons that could fail. One, programs are never going to want to report information that makes them look bad. Two is like certain things like logging numbers are very important to be accurate, but I'll be frank, I think there's certain programs that are very busy that at some point the residents stop logging past a certain number of cases because they're just like, what does it matter if I log my 550th intravitreal injection when I did 549? And so, yes, we want them to log everything as good practice for their careers, but it's just not going to happen. And then there's always this issue. You talked about evaluating applicants is going to become harder. I think it will get harder, but I think the power balance is still skewed. And I think one of the things that could help unskew it is, could we start writing letters of recommendation on a 1 to 10 scale that are actually honest? No one wants to do it because no one wants to tank. Yoshi strongly, I know, wants to do this. He wants to really say this is a A+ student, an A student, an A- student, a B- student. But he knows if he gives them anything less than an A+, he's destroying their chances of matching because everyone else gave their student an A+. Can we come together and just say you're only allowed to write one of these types of letters a year? And then you can't say every 10 applicants, every single one is one of the best medical student I've ever worked with. And you know what? Maybe people would have an easier time evaluating applicants. I don't know, Yoshi, I called you out, so you should go next.
What I love is when you have applicants from the same program, multiple of them, and the same letter writer says each person is in their top 1% ever.
Where are the other 99%? Or go, keep going.
Yeah, I think standardization of information is would be tremendously helpful. But if it's going to be done, it needs to be done well, because it's going to be really easy, for example, for programs to start making rank lists, for example, and rankings like hospitals do. And you know how hospitals specifically work on certain metrics to improve their rankings.
Right.
And I think the program's doing that also, which may be a good thing, but if it's done well, or it could potentially even destroy the culture of some programs. And so I don't think it's an easy, straightforward thing to do. And certainly, if we're going to do it, I don't think it should be biased towards larger programs with lots of resources, and smaller programs may be penalized. But I agree in the spirit that transparency is key.
Well, culture was something you guys both touched on. You cannot get a sense of the culture of a program from any quantitative metric. And honestly, you could say that resources and access to great patient care and teachers is very important, but culture and fit is a huge part of this whole process. And so if you can't quantify that part of it, you're right. Maybe residency, it gets better, but maybe it gets a lot worse where you're like, hey, I know your residents want to learn from this great patient, but instead we need you to go to this didactic course so we can report to our ranking that you attended 50 courses this year and not 49. I don't know. Mrinali, your thoughts?
No, I echo much of what you guys have said. I'm always a big fan of data and metrics. I agree that it has to be done well with integrity to make sure the data is high quality and to make sure that it's reflecting a wide enough variety of metrics that we're not over focusing on something like cataract numbers. But I think that, as you said, this data is out there, and what's out there is actually really bad data, usually hearsay from some random resident who said something, and we all know one resident can do 250 cataracts and another one might do 600 cataracts based on their program and the culture and their surgical skills and how much turnover they had or whatnot. So I think that this is definitely moving in the right direction of removing some of the opacity for applicants and providing more data.
Yeah, I think we all referenced, you just need to make sure that people are not viewing it as a shifting of a goalpost. Now they have to change the goals of an educational program to meet those goalposts. Perfect example in Florida is when they went to whatever they called it, there was the FSAT, the Florida statistical, they just said, hey, your school's gonna be graded A through F based on your taking this test and what your students score, and guess what? It's a great idea in paper because you give more money to schools that score worse, and you support schools that score better, but if you're in the middle, you get kind of stuck. And so schools would, instead of teaching their students, have students just take practice tests all day because that was what the teachers were being graded on, the administrators were being graded on. So there are always downsides. Okay, Yoshi, can you check? Oh, go ahead.
I think that some of the downsides would be mitigated in a transparent database like this, because we're not assigning a grade or a ranking. There's going to be a lot of data points, And I'm sure each one will vary from one program to another. Some may be strong in one, others may be strong in another. And of course, applicants may put a lot of stock in something like surgical numbers or something like that, but there'll be ideally so many data points that there's a kind of a balanced view, and there's no way to game the system per se, given all the considerations involved.
Shaina?
Yeah, I was just going to add, I also think that different applicants have different things that they care about more. So, hopefully if there's enough data points, you'd have enough applicants that value different things, different amounts, and that might help facilitate, basically not all of the applicants wanting one program because of one data point that everyone decided was super important. There's so many factors, like whether or not you have family in town or any one of 50 million other things. So.
Great point. Yoshi, did you check your email? I sent you a virtual soapbox to stand on for this article. So this is an editorial called Authorship Ethics, A Practical Approach. Grant Justin, Ron Pelton, Pascal Loretta, and Gary Legault wrote this. So Yoshi, you recently came on and we talked about predatory publishing. That was a problem on the publisher side. This is a problem on the author side. So run us through this editorial. Why is this important? And what are kind of the common things that people fall into in terms of doing unethical things with authorship?
All right. So this is a very interesting and sensitive topic. The authors tackle the question of ethics of authorship for scientific papers. It sounds like a really dry topic, but it's actually very juicy. And
Only to you, Yoshi.
Come on.
Oh, man. I think it's interesting too, Yoshi. I don't know if that helps you or hurts you, but go ahead.
So, working for several journals and just really enjoying research, I've strong opinions about this. And, when all of us have written papers and when you spend just hours and hours collecting data, analyzing and running the stats and drafting the paper, submitting it, getting rejected, and, reformatting it for another journal, you finally make it. It finally gets in. It's really awesome when you see your name and your team's individuals' names acknowledged in bold at the top of the paper. And, it's a great feeling that your team gets acknowledged by every person who reads your work. And I think authorship is an important thing. So some authors, it's more important than the others. So the first author means you did the most work, you drafted it, you get the biggest kudos. Last author means you're pretty much the boss. It was usually your idea or a project. You provided the mentoring or funding. And those two are really the two that count the most. And when you apply for society memberships and academic promotions, in addition to the volume and quality of papers, they also look at how many first and last author papers you have. Second author is second best, third a little less great, etc. And if you have a great crew, all of this is really easy. You just help each other out, go with the flow, but it can potentially sometimes get nasty. And especially in certain academic kind of settings where promotions matter a lot, where some people might fight over authorship or do unethical things to get their names on papers. And it's something that can potentially tear apart even good research collaborations and potentially get people fired even. So authorship ethics, it's really important. And the editorial does a great job explaining what a legitimate author is and the requirements to be an author on a paper. And it talks about the ICMJE criteria, all those forms that we all have to fill out. But it's legit. It means that you have to have made substantial contributions to the paper, whether it was in data analysis or design or interpretation, and have drafted or edited the paper critically and be accountable for the data, which is an important one. And the authors talk about three concerns. One is the authorship order issue. Another is honorary authorships, and another is ghost authorships. So regarding the first one, preventing issues with authorship order, the authors of this editorial recommend discussing authorship early in the process and have institutional policies for research ethics and how to deal with any conflicts and really have everybody involved in the process. And what I usually do for collaborative projects, one of the first things I always try to do first is to set expectations for authorship order so that everybody knows what their roles are, what the expectations are, what they're responsible for, and to prevent many conflicts later. Regarding honorary authorships, this one's interesting. That's when you tag on a person who really didn't contribute much to the paper, but they might have a big name. So the authors think that having that co-author may increase the chances of the paper being accepted, for example. And it was interesting how they noted that about 20 honorary authorships are by coercion. So basically bullying your way onto a paper, that's probably the worst thing. And this, of course, violates the ethics of research. And the last one was ghost authorships. It's the other way around, where someone did a lot of work or even wrote the paper, but they're not included as an author. One scenario they mentioned is where a student did a lot of the data collection, but they weren't included. But one common scenario that I think that wasn't mentioned in the editorial is when like a pharmaceutical company writes the paper essentially for the investigators, but they don't put their own names on it. And that's not good either. And so the editorial points out that these authorship ethic violations are very, very common in medicine. And I really appreciated their kind of thoughtful rundown on how to prevent such practices from happening.
I have so many thoughts, but I'm going to save them. Mrinali, anything to add? Any crazy authorship stories to share with the world at large?
No, I mean, I think that this is a really important article because it brings attention to an issue that I think many people don't think about and don't realize is so important. So things like slapping your colleague's name on the paper because you use some of their patients, but they weren't involved at all in the study is technically not part of the study. Or telling, some people when they're young might say, let me put my friend's name on this paper, and they really didn't contribute much to that. There's a degree of just not being aware, especially amongst younger people. And then there's a degree of just knowing that it's wrong and doing it anyways. I think bringing attention to how important this is, which has started to happen with having to select the criteria with everything that you co-author, is important. But certain policies, as Yoshi mentioned and are highlighted at the end of the article, are probably useful and helpful to create some sort of culture and standard way to approach these things.
Shaina?
Yeah, I completely agree. I think it's a really important topic, and I think a lot of people, especially younger doctors or medical students, might not even be aware that this is an issue, and they should be. But the one thing I would emphasize is that there are clearly rules. I mean, this criteria is used by multiple journals, and fortunately, we all can speak the same language. We can all follow the same rules. You just have to choose to do it. So it's not like it's different by journal, specifically. So something to keep in mind.
So, I mean, I think there's so many, oh, go ahead.
I think that these criteria and institutional or standardized policies are super helpful, because a lot of these things happen due to the hierarchy that's inherent in our field. There's senior people and junior people, and a lot of these issues, I think, just arise in a way that reflects hierarchical and power dynamics. And having such policies in place would really help with that, I think.
So great points by everyone. I think Yoshi hit the nail on the head. I think one of the easiest ways to prevent conflict with authorship is to establish it at the beginning of the study. I do that with all our students. I always say, okay, this is the presumed order of authorship. You say presumed because it can change. If someone doesn't do what they're supposed to do, or someone does a lot more than they were supposed to do, then it should be fluid. The second part of it is Yoshi referenced that because, again, we have these goalposts, people value things like first authorship, last authorship, corresponding author. Gets confusing, which is most important to your career. I think it's so petty. I mean, I just think that, especially once, even as a faculty have to set the example, I think, right? So whoever is attending, whoever's writing as a senior author, they have to set the example. If you are petty and fighting for every little authorship that you should not be an authorship on, if you're petty enough to say, I want to be third author and not fourth author because of this and because it's more important, I mean, what are you doing with your life and your career? Is that really honestly going to make or break your career? No, and it probably shouldn't be that important, even if it did. If it did make or break your career, then you have to think about what you're valuing in life. Like, it's just not that relevant. We have to set the example, right? So we make a point with our students, if they want to add a student on the project, we say, well, how much work are they going to do? Not to be, mean about it, but just because they need to learn from somebody, hey, it's not just you add somebody, they have to add some value to the project. It could be they collect the data, it could be later in life. Yoshi and Mrinali, I've had situations where I've said, hey, I need someone else to read this paper and offer critical feedback because I don't think it's good enough yet, and I need someone else to help with that. Those are all valuable parts of authorship. But forcing your way onto papers that you shouldn't be on is silly. Forcing your way up the authorship ladder is silly. And my last point is, authorship is honestly, again, there's ethics to it, but all things being equal, if people put in the same amount of work, it's probably more important the lower on the totem pole you are. And I think that this is to advocate for the students out there. If a medical student really put in the work and the effort, maybe they weren't ready to write a paper all on their own, but if they put in the work and the effort and they're willing to edit and they're willing to revise and they're doing all those things, they should be first author at the end of their project. That should not be something that's arguable. And honestly, it matters way more to them for them applying for residency or developing their career than it does for Joe Schmo, resident, fellow, or attending who is trying to get another first author publication on their CV. Okay, I stole the soapbox, Yoshi, it's yours.
Yeah, I think we just have to be, nice to each other. We do research to push the field forward, but we also do it because it's a lot of fun. And it's more fun when you follow the rules, be sensitive to each other, know your team, and it shouldn't be an issue. And I think it'll be good for people listening at the beginning stages of their careers to read this editorial. It really spells out things very nicely.
Well, guys, you guys are very generous. Oh, last point. Mrinali, go ahead.
Just to piggyback off that and echo what you say, Jay, I don't think there's a single paper or a single authorship that is worth more than your integrity, your relationships with your colleagues, and the culture that you're creating at work. And so it always really saddens me to hear or see people really fighting over these things and damaging their relationships over them. Having a clear policy and guidelines, I think, would help that.
You know what? Sometimes there's scenarios where there's a limited authorship. Maybe you had a paper that could have 8 authors, and now you're submitting to a journal where there's only 5 or 7 slots. Well, I'm going to tell anyone who's attending, anyone who's senior, again, in those scenarios, be willing to step aside. If nothing would hurt more than a student who put a lot of work in getting cut from a paper like that. It's not going to matter to you. I always try to volunteer when it's appropriate and say, look, if we have limited authorship, it's fine, and I'm happy. Just list me as acknowledgement if you like. I'm just happy, again, like Yoshi said, that we're pushing this forward. We're teaching students how to do research. We're pushing the field forward, and it's fun. So